So you've seen the individual interviews by two esteemed speakers at this afternoon's session on imager or doctor. I wanted to carry on this discussion and for the benefit of readers to hear what they have to say together and to have a short discussion. Nicola, you mentioned that consultant radiologists in the UK do exactly that. They consult, they're talked about. And this is how you see the future yourself, I think.
Yes, I think it's a term I'd quite like to explain as a British radiologist or a British doctor, that this term of being a consultant in a hospital, so I'm a consultant radiologist, it really, it's equivalent to being a staff radiologist in the United States or whatever, but it truly does mean that I am consulted as a doctor for my opinion, which is biased towards radiology and imaging, over a clinical case. So it would be routine for the intensive care physicians, for example, to come down, or the respiratory physicians or whatever, and to seek me out or a colleague to consult with about a difficult case. And they would present the clinical findings. I have a very difficult patient in the ITU who appears to be septic. You know, we've just done a CT. I know it's been reported, but can we go through the images together? And then I'll ask questions about that, you know, what's the lactate, or, you know, have you done a bronchoscopy? And we'll discuss the case together with the images, and we're part of a team. And, you know, they know us, you know, we work together because we know each other and we have respect for each other. And I'm not just a voice on the end of a phone or some distant remote nobody whom they're not going to bother with.
Jim, would you agree with this?
I would love to live in a heaven like this, but in the Netherlands, but in many other countries, we don't even talk about requests, but it's orders. So the X-ray order comes down, and if you have a good system, you can just view them before you send the patient in for a CT. But if you're unlucky, you don't see this, and then if you have the guts to say, well, I don't think this is the proper investigation, well, all hell breaks loose, because you're ordered to do that. And actually, your opinion is of little value, at least in most institutions. And there is a reason for that. First of all, this has been growing like this for the last 50 years. And the other thing is, and that's the difference with the UK, in many hospitals in the Netherlands, there's a money tag. So if you say, I'm not doing this CT, this is £2 less or £3 less. So you do the CT, and actually you want to do 2 because it's even more money. So there's this strict relation which is between doing a CT, getting paid for that, and well, the real value, the added value, is not paid for. So, for instance, if I see a patient, which I do quite regularly, to talk about an intervention I'm going to do, I don't get any money. The hospital doesn't get any money for that. So we're not even paid for that. So if I take half a day out of my week just to see patients, to talk to patients, this is going to lose the hospital money. So the system is so bad, and we are so that we are not really valued for our opinion, but we are valued for the pictures. And every now and then we have a discussion, but don't dare overruling a physician who wants his CT because he thinks it's important. That's a completely different situation. So we're already not very important to them, and that's so different from I've worked in the UK many years ago, so I know that's a different situation. But I'm not pretending it's any kind of utopia or heaven. I mean, far from it. I'm just pointing out that it is a balance, and that many of us as radiologists, we have so much work to do, and there are so many requests or orders to do studies that obviously there is pressure to get the reporting done, but we shouldn't just look at these interruptions from clinicians as being something that we need to get away from and we need to suppress, because it is only by having a certain number of these interruptions, if you like, where you're acting as a doctor and discussing a case, that you can generate this feeling of being part of a team and mutual respect. I would also argue that it is true I work in a public system predominantly. There isn't a huge amount of private healthcare in the UK, but there is some. But I would still say that what matters is having mutual professional respect and a professional ethical code whereby, if you're a surgeon, for example,
and you actually say to your patient or to the referring physician, I don't think an operation is indicated in this patient, you may well be denying yourself money or the private hospital money, but ultimately it is a question of an ethical code, if you like. You will gain more respect as a practicing doctor by trying to do what is best for the patient. And the same, actually, in the end, is true for radiology. I mean, I think all of us as radiologists would be more than happy to do any study in the middle of the night or whatever, however inconvenient, if it is necessary. But what is so soul-destroying is to have to do, or to feel that you have to do, a whole load of studies that are not necessary, which are actually detrimental to the patient, especially if there's ionizing radiation, just because physicians and surgeons can't be bothered or have forgotten how properly to examine the patient clinically. So, I think, we mustn't be too cynical about this, but we need to be educated as well, and we have to have the courage to say, I don't think this study is indicated for the following reasons. I will do this other study, which would be better for you. Or to question why, or to at least know enough medicine so that you can actually say, so what is the D-dimer in this patient whom you think has got a pulmonary embolus? Or I have, looked at the chest X-ray and there's a left lower lobe pneumonia. I am sure this is the cause of the hypoxia and the chest pain and so forth. And
the problem is, you're right, I'm working in an academic center and I'm working as a civil servant, so we don't have any private. But still, there's a sort of amount of things that have to be done, and you have to take your time off to really talk to the doctor. I sometimes go up to the theater, and when vascular surgeons are doing a bypass, and I just walk in and say, "Hi guys, how are things going?" Just 5 minutes, There's an investment of 5 minutes, and it pays you back a lot of respect, a lot of good friends, and so yes, that's very important. But you have to have the time for that. On the other hand, what I see is. One of the things is we had a very good fortress in the past, and that was the archive where all the pictures were stored. Nowadays, everything is online. Everybody can look at it. And my old professor always said, a lot of people can look at a picture or also think they understand the picture, and that is probably still going around. So I see quite unexperienced junior surgeons looking at CT scans, telling all sort of nonsense and rubbish. Nobody's correcting them. So that is a very big danger. So the availability of the pictures, nobody around to be there watching it and explaining that to them, and they start to make their own interpretations and their own diagnosis. So if you're not around, this, like self-referral, self-diagnosis is the second biggest trouble we can have. So you have to really be there. And the other thing is, many of those things, for instance, ultrasound is very popular in the Netherlands, but surgeons can't read ultrasounds. So they will never have an ultrasound. They want a CT because that looks like the normal anatomy for them. So, and sometimes it's much more appropriate to ultrasound, but they just refuse that. So there's a lot of things to do, but if you're, again, which I said before, if you're part of that team and they refuse your ultrasound, then it's going to be a different thing you can talk about and say, come on guys, what are we doing here?
It's a matter of mutual respect and understanding, and you know the guy you're talking to, and you know that he's always told you the truth in the past. He's not going to suddenly tell you some nonsense. So you have a trust. It's a whole thing about trust with your colleagues.
But then going out and doing teleradiology, they don't see you anymore. Who cares? They just look at their own pictures, and so it's nobody around to correct them and say they're wrong. So I think, coming back to teleradiology, this is going to be devastating for radiology. I have no doubt on that.
Very interesting discussion. Lots of food for thought.
Yeah.
And good luck at the session. I hope it goes well. And thank you very much for sharing your ideas with us.
Thank you very much.